Welcome to our community conversations on COVID-19. I'm Dr. Bryan Williams, president of McCall College, and I serve as the moderator of this series. McCall College is a local, specialized college offering meaningful education to students of all ages. This particular series that we're concluding with this video has a motto of allowing local voices to address local issues. Our goal is to encourage vaccination participation by those who are hesitant. In our county, Valley County, we have 10,000 residents. Approximately 3,000 of those will be hesitant to receive the COVID-19 vaccine. Each one hesitates for a number of reasons. Our series will attempt to answer the main points of concern with trusted local voices of information. And the freedom in that concept we've been talking about, called herd immunity, will only be achieved with the participation of the local population. And so we've expanded our series, which was originally 7 weeks, to now 8 weeks. And this is our 8th of 8 conversations. And we're pleased to invite back Dr. Mike Weiss. And the topic of our conversation tonight is COVID-19 disease, treatment, and boosters revisited. Welcome, Dr. Weiss.
Hi, how are you doing?
I am doing great.
Great.
And I'd invite our audience to go back to our first 2 lectures, which will allow them to catch up on some of the ideas that we've already talked about. And so if there's something that the audience doesn't quite understand, there's a good chance if they catch the first 2 lectures, they'll be able to review it. And so, Dr. Weiss, you've served as a retired physician here in McCall. You've also served as the medical director of our St. Luke's Occupational Health Services for 20 years. Thank you for that service. And you've also worked with several corporations. What do you enjoy doing now?
Well, I'm actually an instructor pilot, and I teach flying at the local flying club.
Wonderful. Do you do backcountry flying?
Yes.
That's a challenge. Oh my goodness.
It is in the smoke, for sure.
Oh my word. Well, thank you for helping that. And so we've introduced them that there are 2 other lectures.
Okay.
Can you give us some indication of what was happening in those 2 lectures that people might want to go back and see?
Okay, so remember, I'm an epidemiologist, okay? And epidemiology is the study of diseases in populations. Our usual involvement with a doctor is when we're sick. We go to the hospital or we go to the doctor's office. We are evaluated, diagnosed, and treated, and hopefully we get better. That's the normal relationship of a patient to a doctor. Epidemiology, in great contrast, is about diseases in populations. As I used to tell my friends who would ask me medical questions, unless there were at least 10 of you, I'm not interested. So
you're great at a party.
So epidemiology is a lot of math and statistics. And we fight disease according to math and statistics. So the first lecture was about the epidemiology of epidemics. The second lecture was about the epidemiology of evaluating treatments and prevention. So how do we decide if a vaccine works or a drug works? Those are the first 2 lectures. Today we're going to update people a little bit about that and talk about why a booster and what are we trying to accomplish. And you may remember I had a watchword. So we talked about the epidemiology of epidemics. It's not the first, it's not the worst, and it's not the last. Okay. Today's 3 words are stop, slope, and self. So I'll repeat it. Stop, slope, and self. So the first thing we're going to talk about is what's called the reproduction rate. We talked about that in the first lecture. Viruses are not even alive. They are pieces of DNA or RNA with a protein coat that gets into your body, injects itself, into your cells, hijacks the cellular reproduction system to reproduce itself. So a virus is the weirdest thing. All it wants to do is reproduce itself. Has no other function. Unfortunately, sometimes when it does that, it makes people sick. But it doesn't care about making you sick. It just cares about reproducing. And when a novel virus, like the coronavirus, appears, there's a number called the reproduction rate. And they often call it the R0. And that is the reproduction rate in a population that is completely naive or has never been exposed to that virus. Okay? So that's called the R0. Now, when the COVID first, and the reason the reproduction rate is so important for epidemics is that if the number is 1 or less, there's no epidemic. If the number is greater than 1, there's an epidemic, and the higher it is above 1, the faster it reproduces and the harder it is to stop. Okay. So the R0, when COVID first appeared, was between 2 and 3. And the R0 of the Delta variant is probably closer to 6. And I'll tell you why that's so important, okay? So let's talk about R's, reproduction rates. There's a thing also called the effective reproduction rate. This is when the epidemic's already going on. And if we can have the board here, and if you can see it, I'll show you the formula for this. This is the real important one. So the effective, can you see that?
Yep.
So it's R sub E equals, 1, or actually equals R0, which is the reproduction rate in the unexposed population, times 100 minus the percent of the population that's immune. Okay? So, if 100% of the people are immune, the effective reproduction rate is 0 times whatever this is, and so the effective reproduction is 0.
Sure.
The virus disappears. Okay? If it's less than 1 means that one person who has the infection, comes in contact with people who are susceptible, and during the time when they are infectious, which for COVID is about probably about 10 days, 7 to 10 days, they transmit that infection to one person. That's a reproduction rate of 1. And you can figure out if that's true, that one person will have it, get better, give it to one person who will have it and get better, give it to one person who will have it and get better, but it never goes up. There's no epidemic. If it's less than 1, they give it to, they don't give it, they might give it to one person or they might not give it to one person. So if it's let's say it's 0.5, it's half, then the next generation, if it's like one person, the next one will be maybe half a person, and then the next one will be a quarter person, and then it'll be gone. The virus will be disappeared. If it's greater than 1, let's say it's 2 or 3, it goes up exponentially. And it makes a big difference. If it's 3 and the infectious period is about a week, in a month there's 128 people who have the virus, from 1 to 128. If it's 6, it's a couple 100,000. So it makes a tremendous difference. So what we do when we fight an epidemic from an epidemiological standpoint is we do everything we can to get this number less than 1. 1 or less, epidemics gone. More than 1, it increases. And it goes exponentially. So even if it's a little bit above 1, it's still going to grow very quickly. If it's a lot above 1, it really grows quickly. So the reason this epidemic is so tragic is that currently it is a optional epidemic, and it drives doctors nuts. Because, and in fact, I think I was telling you, I went in for my Medicare wellness check, and mainly my primary care provider was venting about how frustrated she was, having just come from the ER, taking care of all these people who had COVID who didn't have to have it, okay? Because remember, the original R0 for the virus was 2 to 3. So let's say it's 3. All we have to do is get 2/3 of the population to be immune, and the virus goes away. Okay,
Sure.
that was possible, okay? We had a vaccine that was good with a 95% efficacy, okay? And we could give it to people ages 12 and over. Great. Turns out that about 15% of the population is under 12. So we can't give it to them. So that's 15 out there, okay? 15% can't get it,
right.
okay? 5% of whoever we give it to, it's not going to work.
Sure.
Another 5%, okay? So now we're 20%, okay? Okay. And let's say, but if we gave it to everybody else who was eligible for it,
Sure.
and maybe there's some people who can't take it because they're allergic to the vaccine, okay? Let's say that's 1%. But let's make it higher. Let's say 5%, okay?
Okay, sure.
But it's actually much less than that. So now we're at 25%. But we've only got to be at 66%, and that virus goes away. And we could have done it because we had a vaccine that was 95%. Now, let's look at the current situation. R0 now is 6. And the fact of the matter is, we cannot make the virus go away. Even if we can start vaccinating people under the age of,
Of 12.
12,
Sure.
we're still going to have little kids, maybe 10% of the population we can't vaccinate, okay? Maybe 5%, and then people who can't take it, and it only works 5% of the time, so you're already over 20%, and if it's over 15%, with an R0 16, it reproduces and you have an epidemic. So it really, right now, in terms of the first word, stopping it, it's not possible. And as the virus mutates, it may become more virulent or makes people sicker, or it may not. And the virus doesn't care about that. All it cares about is reproducing. And so the higher the reproduction rate, if we come up with another variant that's more infectious, maybe with an R0 of more like measles, which is 18, then it's hopeless, okay? You'd have to vaccinate everybody and get this number to 0, almost. You'll never get there. So that water is under the bridge. So what's the next word? Slope, okay?
Okay.
The lower this number, above 1, we still have the epidemic, but the slower it goes up. Okay. So we talked about flattening the curve, I think, in the first lecture, and that would be our goal now. We are overwhelming our hospitals, our ERs. I think there's like 6 ICU beds in the state of Idaho right now, and in northern Idaho, they are turning libraries and meeting rooms and cafeterias into beds for the hospital. They're just overwhelmed, and they don't have the staff to staff that. And you have to remember that, again, like a war, we have collateral damage. So right now, we're having in the United States about 1,500 deaths a day from COVID, but we're probably having collateral damage to the people who don't get in the ERs. You know, the people who aren't having their cancer taken out or aren't having their heart attack treatment. You know, they have chest pain, but they can't go to the ER because they're afraid of getting COVID or there's no room there. And they die. That's collateral damage. And it's really sad because you have to think of a virus, an epidemic, as an invading army. And we should be fighting it as a country. I talked about that. It's our patriotic duty to fight this as one country. And instead, we're divided. If we'd had the same attitude in World War II, and by the way, the number of deaths so far are actually 60% more than the total number of deaths we had in World War II. And we're probably going to have twice as many deaths as World War II. And if we'd had the same attitude towards World War II, we'd be speaking this talk in either German or Japanese. Because that's how bad we have divided ourselves. We're divided, and we're being conquered by this horrible disease. That's the bad news, okay? You want some good news?
Sure.
Okay. Okay, well, the good news is goes back to, remember the watchwords for the first lecture.
Yeah.
It's not the first, it's not the worst, and it's not the last. Okay. Let's talk about how it's not the worst, because I think people get freaked out by it, and some people just minimize it, but they shouldn't, okay? Measles, when it first appeared, okay, had a mortality rate of about 20% of the people who got it died.
Sure.
Smallpox, when it first appeared, had a mortality rate about 25%, and of course the Black Plague was about 40%. Okay. When this first appeared, the general mortality rate of diagnosed cases was 2%. Okay. That's come down. We're having 150,000 cases diagnosed a day in the United States. We're losing about 1,500 people, so it's now down to 1% of the diagnosed cases. Now, if you go to the University of Washington, there's an Institute for Health Metrics and Evaluation that actually estimates how many cases are actually out there, because one of the interesting things about COVID is that a lot of the cases are asymptomatic. People don't know they have it. Some people die, some people get very sick, some people get a little bit sick, and some people are asymptomatic. That's just the way it is. And they estimate that probably we're diagnosing about 1/3 of the cases. So that means our 1% is now 1/3%. Now, how does that compare to the flu? The flu is 0.1%. That's the mortality rate for the flu, and usually. So we're about 3 to 4 times worse than the flu. And that makes sense because countries that do better statistics than us and have more organized healthcare systems, like the United Arab Emirates, their initial mortality rate was about 0.4%. So about 4 times worse than the flu. And that's about what we're approaching now. So that seems to make sense. That makes a lot of sense. So and now this is the really good news, okay? Epidemics, there weren't always vaccines, and the human race has not been wiped out so far by epidemics, even much worse epidemics than COVID, like measles or smallpox.
The plague.
Yes, or even the plague. Mm-hmm. So we're not going to be wiped out by this. This is not a threat to civilization as we know it. And eventually, after a few waves, like the 1918 Spanish flu, this will go away. This will go away. And in fact, one of the ironies is that the worse it is, the faster it goes away. Okay, if you have measles goes through a population like wildfire. I mean, every one case produces 18 more. I mean, you only have so many people who can get it. And pretty soon, the whole population's been sick. The ones that die, die. The ones that have long-term side effects have long-term side effects. Measles can cause encephalitis, brain damage. And the ones that survive, healthy, go on with their life. And they may get measles again if their immunity wanes, but now their body's been exposed to it. So that will happen here. But we may overwhelm our healthcare system. When the Delta variant first appeared in India just was overwhelmed. People were like dying on the streets outside of the hospitals. But it went way up, and then it went way down. And their incidence now is actually very small. They don't expect another wave in India because everybody who's going to get it got it. Yeah. And the ones who are going to die, died. Right. But the sad thing, especially for doctors treating this and trying to save people, is that the ones who died didn't have to. This was optional. And it isn't just old people, and it isn't just fat people, and it isn't just people who are out of shape or have diabetes or whatever. A certain percentage of young kids will die. That's what happens. It may be a small percentage, but if it's your kid or your grandchild, that's horrible. And it didn't have to happen. I went to a funeral of a good friend of mine just on Saturday, Chad DeBoer, a local guy who died of it. And he is older and he had other conditions. He's a really good guy. We lost him to our community. And that's very sad, very sad. So I would have liked to have had him around for another 10, 15 years. It would have been great. So, and people can say the same thing about their grandparents, about their kids, about their cousins. It's just tragic. And like I said, it drives doctors and nurses nuts. Okay. So that was the good news, because this will go away. And actually, if you go to the University of Washington site, the IHME, the Institute for Health Metrics and Evaluations, you will see that they actually have models, which are pretty good, where they predict the total number of deaths and when the epidemic will start to drop. And we probably are pretty close to the peak of infections right now in this country, because we have half the population or so has been immunized. It's probably closer to 60%. I think it's 58%. Okay. We have had, if we've had 600,000 deaths, and the mortality rate is half to a third of a percent, then we know by multiplying that by 25 that we are over 100 million, close to 150 million of people who have got it. Okay. Now, some people who have gotten it have also gotten the vaccination, so there's overlap there.
Sure.
But we're probably pretty close to about 80% of the population being immune right now. We do know how well the vaccine works in terms of immunity. Okay. We do not know how well having the infection works in terms of long-term immunity. Just don't know. We'll know sooner. So we can expect the infection rate to start dropping, hospitalization rate to start dropping, the death rate to start dropping nationwide. But in those areas where there's more people who are not immune because they refuse the vaccine and they haven't gotten it yet, with this more infectious, then it's going to keep it going up. And that's what we're seeing in states that have very low rates of infection. That's what we're seeing of vaccination. That's what we're seeing in Idaho. Counties like Blaine County, which has an 80% vaccination rate, Ada County and Valley County, which are pretty good, I think we're in the 60s, are doing much better in terms of utilization of medical resources than counties like Idaho County, which has about a 30% vaccination rate. So they're going nuts up in northern Idaho, and we're relatively better, but eventually it'll come down again. The government is helping somewhat by sending in the armed forces with mobile clinics to help bolster the local resources to avoid some of that collateral damage, as they should. But there's so much demand nationwide because we've been so divided that they just don't have the resources even to do that.
Thank you. You've talked about stop and you've talked about slope. Are you going to talk about self, or is that coming later?
That's coming right now. Very
okay.
good.
What's self mean?
Okay. Well, and self should be a sort of. Because self means that you're interested in whether you're going to get sick and die. And we know that with the initial vaccinations, these vaccines are terrific as vaccines go. We know that the mRNA vaccines have about a 95% effectiveness for what they studied it in. And initially they studied in about 40,000 people, and they looked to see if they would get sick and die. Would they be admitted to the hospital? Would they die? What they haven't really looked at is if they get infected but don't get sick and die, are they asymptomatic? And we know now that it works great. You get a vaccination, the odds of you going to the hospital, I mean, you talk to any ER doctor. One of my primary care doctor was venting. She said she took care of all these patients. None of them had been vaccinated. Okay. St. Luke's today reports that 90% of the patients in their ICU who have COVID have not been vaccinated. So that's, if you get the vaccine, it works pretty good. I mean, a lot of places are saying that almost everybody who's dying going to the intensive care unit is unvaccinated. That means the people who were vaccinated were protected. So it's really up there, over 95. Now, they really didn't look at whether it stopped an infection that was symptomatic. They were interested in whether you died or whether you got really sick. So they didn't know. They have used what are called antibodies that are produced by the vaccine as a indicator of how protected you are from infection. But antibodies are just one part of the immune system. There's also what are called memory T cells that produce antibodies when they're but you keep those a long time. The antibodies may go down, but you can start producing antibodies really fast. So, but they want to keep the antibodies levels up to try and avoid any infection at all. They have shown that people who have high antibody titers or amounts in their blood, if they do get an infection, it doesn't stay, they're not as infectious as long. So a person who has the normal course of the virus will be infectious for a couple of days before they come down with symptoms, and then about 5 to 7 days after they start to get better. Okay? So it's about a week to 10 days. So, but if you have been vaccinated and you have high antibody titers, it's only about 3 days. So that's good. That'll lower that effective rate of transmission. And so if they keep your antibody titers up, they can use that to try and suppress the virus, cut the slope down. They're not going to probably get rid of it, but they can cut it down. And when you get the booster, your titers go back up. So they're hoping that you'll be less likely to get what they call a subclinical or asymptomatic infection, but you can still spread it to the poor people around you who haven't bothered to be vaccinated or can't be because they're too young or have contraindications, like they're allergic to the vaccine. So you are protecting yourself from getting infected by the booster shot to some degree. You're lowering that rate. And you're protecting the people around you. So you're actually, that's why I said sort of, because to some degree the booster shot is to help flatten the slope, to flatten the curve. And to some degree the booster shot is to protect, that 10% of people who are vaccinated who are in the ICU might, if they get a booster shot, they might go down to 1%. So it might help protect them individually, but also protect the people around them. So that's the rationale for the booster shot. And they're working on the studies for that now, again, using antibodies, not so much whether you get hospitalized or die from.
Thank you. I'd like to go to our goal now, which is to encourage our vaccine hesitant folks to get the vaccine. And so we'll come back to this later, but right now I'd just like to get in there. After all we've been through, what would you like to say to our vaccine hesitant population at this stage of the epidemic?
Well, a couple that we were going to talk about treatments also, okay? Mm-hmm. And I do know that it is odd to me that some people who are anti-vaccine are looking for a miracle cure. And I can understand that because in general we come up with treatments before we come up with vaccines. We came up with like AIDS is a good example. We have good treatments for AIDS now, but we're still working on the vaccine. So this one we got the vaccine first, strangely enough, using technology that was developed for AIDS, and we haven't got a good treatment yet. Now, when this first appeared, so more than a year and a half ago, a number of institutions, the one I was most familiar with was the McMaster University in Ontario, Canada, started a project using supercomputers actually to look at all the thousands of drugs that are already out there, and some of which are under development, to try and find one that works. And initially they thought hydroxychloroquine was a good idea. The way these things work with drugs that are already out there is somebody who's on hydroxychloroquine, for example, for arthritis, it's used for that. They noticed that those people somebody noticed that they didn't seem to get COVID. And they reported that. And then so somebody did a study where they looked at people who were they gave hydroxychloroquine randomly to a group of people, and they didn't know they were on it. That's called a double-blind study. And what they found is it didn't work. And all you got were the side effects and none of the benefits. The same thing happened with ivermectin. I have ivermectin in my refrigerator. I give it to my dog for heartworm. Okay, and there were reasons they did it. Someone noticed that when they put ivermectin in a culture of COVID, that it seemed to suppress it, and so that produced studies to see if it worked. What they found is they had to use thousands of times the dosage to get it to do it in mice. And then they stopped studying it because that would be toxic in people, and that's what they're finding. People who are trying to take ivermectin remember, a lot of people be asymptomatic and get better anyway, so you can't just say just because you took it and you got better, that's what cured you. And so what they found is that people are having side effects, which are nausea and diarrhea and so on, and not getting any benefit from it. So that's off. But there are other things they found. They found that in people who are very sick, that steroids, very inexpensive medication, improves survival. So that's part of the standard treatment. They found that a drug that was developed initially for Ebola, which is called remdesivir, had shortened the length of stay and improved survival in people who were in ICUs, and that became a standard treatment. That was the first treatment that was approved. Now, the odd thing is that people who are against vaccines say, oh, let's do the treatments. Well, first of all, what's really ironic about remdesivir is they're now promoting it when you first get sick. It hasn't really been studied that well. It may work, it may not. But the regimen for that is 4 subcutaneous shots. So you're turning down 2 vaccines that are 95%, 2 shots of a vaccine that's 95% effective initially, and then maybe 6 months later or 8 months later you get a 3rd shot, and then it's still 95%, maybe more, for 4 shots. And the bad thing is, of course, that if you wait until you're already sick or coming down with symptoms, you've probably already passed the virus around. So you're not stopping it or cutting the slope down, you're just protecting yourself. And that's the other thing, is that you're really pretty selfish when that you do that instead of taking a booster shot or taking the vaccine initially. If you really want to stop this thing or slow it down, avoid collateral damage, function like with the seriousness of repelling an invading army, you got to get vaccinated.
Excellent. So I think if I were to summarize what I'm hearing, it's so many in the vaccine hesitant community has focused on the treatment, but there's exceptionally good prevention.
Yes.
Focus on the prevention. And if you focus on the prevention, you'll take the vaccine.
Yeah, and you'll stop the epidemic.
And you'll stop it.
If you wait until there's a good treatment around there, you may help yourself, but you may still transmit it to someone who's in school. And by the way, all the other stuff we talk about, separation, washing your hands, wearing a mask, those are all interventions to decrease the transmissibility. They're not perfect, but there are countries that have done that. Singapore, which has a much lower vaccination rate than we do, has hardly any virus because they mask everybody and they keep people separate because it works. It gets that reproduction rate down enough so that it gets below 1. That's all that matters. You can do it with a vaccine. You can do it you can do it by staying home. You can do it with a mask. It all helps. You can do all of them, and they help. But that's the strategy, and we're not following any strategy when we all are our own generals in fighting this. It doesn't work.
There's a couple moral concepts I'd like to take you to.
Sure.
Just for a moment. We really haven't dealt with the moral concepts of what's happening with the epidemic. And if you don't mind, with my background as an ethicist, that's where I prefer to enjoy the conversation. And so the question I'd like to offer you is, how do the concepts of individual choice and social responsibility fit in to this epidemic, into this pandemic that we're dealing with?
Well, the problem is, and I've confronted this. I met with a pilot just this weekend who's a retired United Airlines pilot. He said his doctor told him, don't ever take any vaccines. Don't ever let them put that in your arm. I don't know what kind of doctor that was. That's interesting advice. But he decided to follow that advice. So he's never had a vaccine for anything. He's still alive. That's good. Okay? But if he gets sick, he's going to transmit it to other people. He may die. He may get really sick fast. Maybe that would decrease his transmissibility. But he's certainly not participating in a concerted effort on the part of the population to follow our leaders. And they may give good advice. They may give bad advice. I was in the Air Force before I went to medical school. I did not always agree with my orders. But I didn't say, well, it's my right not to follow my orders. Like that, they don't like that in the Air Force. They put you in front of a firing squad if you do that. So now I don't think we should have firing squads. But I also think that, as Governor Ivey down in Alabama said, is that you'd think people would have common sense, you know? And common sense says that when something is invading us, that we fight as a group, we're patriotic people up in Idaho especially, you know, we have flyer flags and so on. I have fly mine every day. And a lot of people around me do the same thing. I like to see that. But that means that we function as a country. We don't function as, you know, if I want to get this virus and give it to somebody, it's my right to do it. Now, this guy, this pilot, I felt like he was a 5-year-old. You know, you have kids. You know, I'm not going to do it, and you can't make me. I mean, that's a classic 5-year-old response to, like, going to bed, brushing their teeth, you know, whatever. And I feel like this is juvenile. You know, why am I having to have this argument? As Governor Ivey said, you'd think someone who's an adult would have some common sense. And as far as I'm concerned, I don't like the idea of mandates. I don't know why we have to say that everybody who works for the government has to be vaccinated or have tests. Everybody who works for the school has to be vaccinated or have tests. You can't force people to wear masks. You can't do this, you can't that. They should want to do that. They should want to get together as an ethical community responsibility to fight this thing off. It's killing people, and not necessarily.
Thank you for handling those. I'd like to take you now back into the disease itself.
Okay.
As we identify some things. What do we need to know now about COVID-19 and its original variants?
Boy, that's an excellent question. This has been around for a little less than 2 years.
Okay.
We know a lot about it, but not nearly as much as we're going to know in 10. We're still finding out things about smallpox and tuberculosis. You know, tuberculosis they found in the ancient Egyptians. We're still learning about it. So it's been around for, you know, 8,000 years, and we're still learning about this thing. So we're going to learn a lot more. And that's another reason to take the vaccine over just getting natural immunity from having the virus itself. Some people say that's better. Well, we don't know if it's better. We know it's there. Once people have got it, they have some immunity. We don't know how long it lasts. We don't know how it covers the variants that appear. But we really don't know is what the long-term side effects are of the disease. You know, and so we'll find out in the next 10, 15, 20, 50 years. We'll learn a lot about what the long-term side effects of COVID are. I still think it's better not to get it at all.
We're starting to use these variants pretty routinely in our language.
Mm-hmm.
They've used the name or the nomenclature of Delta on the current variant. How's the average person supposed to understand variants and this term of Delta? What's that mean?
Okay, well, first of all, there's actually a more complicated system for naming the mutations that occur. And, you know, a virus produces, you know, millions of copies of itself in every person. Every time it makes a copy, there can be a mistake in the reproduction. That's called mutation. Okay? And some mutations are bad, and the virus dies off faster. Some mutations from the virus standpoint are good, and it produces more of itself. So that R0 goes up to 6 instead of, so if it's up to 6 and it's competing with another virus variant that's got an R0 3, well, that 6 one's going to outproduce it like crazy. You know, it's going to be 128 of the ones that are 3 and 200,000 of the ones that are 6 in a month. So you know that's the one that's going to predominate. Now, they just decided to make it clearer to name the variants based on alpha, beta, gamma, delta. So the 4th variant they've identified is called Delta, and it originated in Brazil and India, and it's much more transmissible. So from the virus's standpoint, it's great, and it's going to dominate, and that's what's happened. So I think more than 90% of the isolates in the United States are Delta now. And Mu is a new one. We also don't know if the mutations become resistant to the vaccines. So far they have not. And we also don't know if the mutants are more what they call virulent, make people sicker. Again, the virus doesn't care about that, and there's some chance that a mutation would not make people sick at all, or make much less, but still have a higher reproduction rate and then become the dominant strain.
So when we hear about a new variant, a lambda or a mu, is that a cue for us to be more cautious because something different is happening? How should the average person, now that we're beginning to talk about the mu variant,
right?
How concerned should they be?
Well, it depends. Okay, first of all, if you're concerned about it, let's get rid of this virus. We could have done that. We could have gotten the vaccine. Bhutan, where they have to go to get their vaccines in a yak-pulled ox cart. Okay, they vaccinated 90% of the population in a week. To Bhutan, and we can't do it in this country. It's embarrassing. So we could have gotten rid of this. Now we really can't. And so the answer is it depends. Okay, if the variants are more virulent, we're going to have more people in the hospital and the ICUs, and it's going to be worse. More people dying. So instead of maybe 1/3% dying who get it, it might go up to 1% or 20%. We don't know. Remember, it's mutating. The virus doesn't really care, but that might happen. So whatever it is, though, the ones that predominate. So if the mu variation, which does not appear to be more transmissible than the delta so far, but if it is, then we'll find out that all people getting it will have gotten the mu, because it'll outcompete the delta, which outcompeted the beta, which was the one from England. So it's hard to say you should be concerned or not. But I tell you that CDC, which monitors this stuff, that there are generals. The reason we have a surgeon general and not a medical director of the public health department, okay? Because it's like a war. And he's developing a strategy with his lieutenants and so on to fight this war. It'd be nice if we, as his troops, cooperated with the battle plan. It may not be the right one, but he's the general, So I think that that they're monitoring it. They're monitoring the strategy of the enemy, and they're making adjustments in the battle plan to try and defeat it. Okay? Just like they did in Germany and against the Japanese in World War II. That's how you fight a war. And so we should pay attention to our best sources of information. The Center for Disease Control, University of Washington School of Public Health, there's several people out there that are eminent virologists and epidemiologists that are trying to defeat this invading virus. I think we should pay attention to them more than we pay attention to an influencer on YouTube or TikTok or somebody who's being like that 5-year-old saying, I'm not going to do it and you can't make me. I don't take a lot of advice from my 5-year-old granddaughter, okay, about how I live my life. Okay? I love her dearly, but that's not the way an adult, as Governor Ivey said, you'd think people would have common sense.
How likely is a person to get COVID-19 in their neighborhood? I'm hearing stories around my neighborhood of people that are sick.
Oh, yeah.
And if you were to say, okay, there's 100 people in my neighborhood, how many of us are you estimating right now, as a statistician of disease, that are going to have evidence of symptoms right now of those 100 people? Is there a way to quantify it like that?
There is, although it's difficult. The best way to do that would be to do surveys where they measured for antibodies. And they did that initially. In fact, and there are countries that do this. The standard way you fight an epidemic is not developing a vaccine within a year like we did. That was tremendous achievement. Amazing. Operation Warp Speed will go down in history as one of the great achievements in science. It really is truly remarkable. But the way you do it is you isolate cases and you quarantine people and wait for their infectious period to pass so that they can't pass it on and keep that reproduction going. That's the standard way to do it. That's the way they do it in New Zealand, for example. Very effective. Also a lower vaccination rate than we have, but has because they've kept the numbers down, they've been able to use standard techniques of fighting epidemics through public health to fight the virus. We could do that if we could get the reproduction rate to a manageable level, and hopefully we will at some point. But it's the way we're doing it right now. So anyway, to answer your question, what you can do is you can look at what percentage of people who are tested for COVID, that come into the ER with symptoms, or they go to Rite Aid because they're going to travel to Canada or something like that, and they get tested, what percentage of those tests are positive? Nationwide right now, it's about 9%. Okay. In Idaho, it's about 23%. So we have, and again, some people are tested because they're symptomatic, and some people are tested because they want to travel someplace and they have to get a test before they get an airplane or something like that. Okay, so they're likely to have lower rates than people who are sick. Okay, but 23 is a lot higher than 9. That we have a lot more of the virus circulating in Idaho than they do nationwide on average. So that's one way. Another way to get a sense of how prevalent it is the number of cases that are diagnosed per day, per 100,000. And we, in Valley County, I believe, are right in the 40s. We're averaging about 6 cases a day. For a while, we were averaging about 3 cases a day, and actually, for a couple weeks, we had no cases. We were also averaging a couple deaths per day, but now we're not getting many deaths, again, because the mortality rate has gone way down. It went from initially, 1% maybe down to 1/3%. So that's good. We're getting much better at treating it. If we overwhelm our healthcare facilities, it may go up again, unfortunately. So we can see, and actually I think Ada County is about in the same ballpark, about 40 per 100,000, something like that. I think it's a little higher. But that's one way you could estimate the prevalence, how many people are infected. But it's out there. If it's not out there, like I said, the best way to defeat an epidemic is don't have the virus out there. Okay, if the R0 is, if there's no virus, everybody's immune, there's no epidemic.
So if we now admit that the virus is circulating in our neighborhoods, we need to use the tools available to us to maximize our own response and to maximize our neighborhood response.
Yeah.
Now, we've got a couple tools. We've got the vaccine. We've been talking about that.
Yeah.
But let's take a moment and talk about the prevention of the disease, and that's with masks and social distancing. Let's focus on masks. Physicians are trained to wear a mask. They do it routine, and the rest of the health community are quite comfortable in masks. Our community is extraordinarily uncomfortable with masks, but we've never really stopped to think about what would it mean if our masks were extraordinarily uncomfortable and people don't want to wear them. Can you give us a little bit of advice from your long history within medicine of how do we make these masks comfortable so people will want to take them? I would argue that's a primary reason, is these horrible little paper masks are really uncomfortable. You just seem like you're breathing your own breath all the time. And why would anybody want to wear these more than a second or two? So help us to get through the mask barrier if you can.
Well, doctors and nurses, people who work in hospitals, wear masks to protect their patients. They don't wear it to protect themselves very much. Mainly it's to protect their patients. And like when you do a surgery, you're protecting the patient. You're not really protecting yourself. And a lot of people are saying, well, am I protecting the stupid person who didn't take a vaccination when I'm not likely to die? What do I care about them? And that's morally wrong. Hopefully the Hippocratic Oath tells you shouldn't do that. So as a doctor, we're wearing masks to protect people who are stubborn, our 5-year-old. We're also protecting people under the age of 12 who can't get vaccinated. And that's why it's so important in schools to wear masks. And again, because people are going back to school and some places are wearing masks and some people are not wearing masks, we call that a natural experiment. And you know what we're finding? We're finding out that schools where they wear masks, they don't have outbreaks. Okay? Especially in a community that has high rates of vaccination. None of the kids in the school are vaccinated. Okay? So having the community vaccinated decreases the prevalence, how much virus is out there. And in the schools where they wear the masks, teachers are vaccinated, they don't have outbreaks. And my grandkids two of my grandkids live in Oklahoma, which has a lower rate of vaccination. They've had to close the schools down twice since the school started a few weeks ago because they had outbreaks. And even though they're wearing masks mostly, it's Oklahoma, it's very much like Idaho. People don't want to do it. And my grandson doesn't mind wearing a mask. He's 9, and he's just fine with it. He thinks it's cool. And you can present it that way. You can say, you're a ninja. You're one of the mutant ninja turtles, and they wear masks. That's great. And so I think it's how we present it. If we present it as a sign of freedom, as a secret sign to our co-conspirators that we're not going to wear a mask because we don't believe in the virus and it's going to disappear if we just don't believe in it, kind of like not clapping for Tinkerbell. Like I said, a lot of this is at a 5-year-old level, okay? Then I don't know what to do with those people. And maybe we have to make it mandatory, make it so inconvenient. You got to get tested like 10 times a day with a Q-tip stuck down your nose, and you're going to then decide, I want to get vaccinated. Maybe that's what we have to do. Maybe that's what you do with a 5-year-old. But again, these are adults, and you just look at these people, and you just, as a doctor, you just shake your head, and you go, what in the world are you thinking? So please think like an adult. Get your information from people who know what they're doing, who are trained, who are dedicated researchers. Center for Disease Control is a world treasure. World Health Organization is good, but it relies a lot on Center for Disease Control. And you can get good information from their website. cdc.gov has tons of information that is really good. University of Washington, Johns Hopkins University have great sources. Don't get your information from a TikTok influencer who wants you to get upset so they get lots of hits and lots of likes and lots of retweets, because that's how they make their money. I mean, they have a secondary agenda that's not in your interest, and you should know that. You're an adult.
Let's go back to that McMaster study.
Yes.
Because again, we spent a lot of our time trying to talk people out of a lot of the treatment ideas that are floating around from the influencers on social media. Did the McMaster study shine a light on anything that's new, that's different, that we probably haven't heard a lot about, but actually might be helpful?
Well, I think they looked at 70,000 different drugs. I mean, they really looked at everything. They looked at all the stuff that's on the market. They've looked at all the stuff that is being developed. I mean, there's a lot of stuff out there. One of the things they found, they found initially was Pepsid, which is famotidine. It's an antacid you take over the counter. Unfortunately, it didn't work. It seemed like it worked at first. Again, you get case reports. It makes some sense from what you know about the chemistry and biology of the virus, and then you do studies. Okay? Initially, you might do them in a lab. You might do it with an animal, and then you do it in a group of people, and then you do it in a bigger group of people, and you do what's called a double-blind study. We talked about that in the second week, where you have double-blind case control, where the patient doesn't know what they're getting, the doctor doesn't know what they're giving, and after a certain period of time, you break the code and you find out who got what, and then you can figure out whether it works or not. Especially if it's if it's a really good effect, it'll be obvious. If it's a slight effect, it's a little trickier to get. And you also might want to repeat the study, because sometimes statistically you'll get just a variation with the way people are. I talked about that the second week too. Any disease in any person will get better, get worse, or stay the same. Just because you're waving your hands around when they get better does not imply cause and effect. Basic rule of epidemiology, and that's has to be done with good scientifically designed studies. So famotidine, Pepsid didn't make it. Okay. One drug that seems to be doing okay, there was one study that was small, double-blind, with a drug called Luvox, which is actually a generic antidepressant medicine. Not all antidepressant medicines work. This one is unique and seems to be effective. It's fluvoxamine, I think, is the generic name for that. And it is, in the smaller studies that have been done so far, it's been effective for treatment of early COVID. Be great. It's a pill. Fabulous. Instead of the 4 shots for the remdesivir. And if it works, we'll know. But it's got it. They've identified it. They had reasons to look at it, and I think that came out of McMaster. And if it works, great. If it doesn't hold up in the studies, then you have to accept that. And the first study's not enough. You got to do repeated. And if it works, it will show that in repeat studies. That's how the scientific method works.
Thank you. Let's go back to children just for a minute.
Sure.
Are children at higher risk of the new variants, particularly Delta? And is the disease itself different in children?
Good question. We don't know.
Okay.
Some children get sick. Some children die. None of these kids are vaccinated because there's no vaccine for them, although a lot of doctors that I know have enrolled their kids in studies because they want their kids vaccinated. And they'll participate in the studies, have a 50% chance of getting the real vaccine and not the placebo, so that they believe in it so much. So some kids are getting vaccinated. And it seems the vaccines, they have to figure out the dosage, whether you give 1 shot or 2 shots or 3 shots or half the dose. It's a complicated thing. Kids are not just small adults. And so right now, I believe they're looking at 2 years to 11 years as the next group that probably will have an approved vaccine by the end of the year. Kids seem to not get as sick with COVID. They're less likely to die or be hospitalized, although some do die and get really sick. As I understand, we've had no deaths in Idaho, although nationwide we've had quite a few. And in any child, losing a child is like the worst thing that can happen to a parent. My parent hasn't had nightmares about that. And God bless and protect the ones that have suffered that. But if it's not necessary, let's do something about that.
Let's move on to boosters.
Okay.
Boosters seem to have a plus and a minus here. They seem to, obviously, and you've mentioned how a booster will do what its name is. It will boost your efficacy, it'll boost your titer, it'll boost the amount of antibodies available so that you can fight the disease with better efficacy. But it also means that things aren't going well. And so how do you approach boosters, and whether we should be waiting with bated breath for these boosters?
The answer to that is no, okay? Because remember, the boosters are looking at the antibody titers, okay? And so it's like I got my shot, and I got my first shot, and I donate blood regularly. And the Red Cross used to test your blood when you donated it to see if you had antibodies to COVID. So I got my first shot, and I got donated blood a week or so afterwards, and I had a negative antibody titer. I got my second shot, and the next time I donated blood, I had antibodies. So it worked, okay? They stopped doing that. They didn't do it because they were being nice to you. They actually would sell your serum as a therapy. So and they just told you what the result was. So they were testing all the blood donations. And they've stopped reporting it for some reason. But the point of it is, the antibody titers seem to fall off with time. But remember, the tests of the original vaccine were not antibody titers. They were whether you died or got hospitalized. Mm-hmm. So, and it's not really clear whether your risk of dying or being hospitalized really falls off that much with time. That's why I said sort of with protecting yourself. You can boost your titers with a booster shot, but you're mainly just shortening the length of time which you carry the virus and transmit it to people who haven't been vaccinated. So that's part of the rationale for the booster shot. Although it does seem from studies in other countries that it does decrease your chance of getting sick and dying too, but it goes from low to very low. And the next question is, will it sustain that? We don't know. We've only, I had my second shot in February, okay? So I'm still in my, I'm still not, just coming into my 6-month phase here where I should get my second shot. And I will, I'll get my third shot, my booster shot. I'll do it, because if it's recommended by the CDC, I follow my general's orders. I was trained to do that before I became a doctor. So So I think, and again, I think it will help. It's like wearing a mask in some degree. I'm reducing my risk of transmitting it to my grandchildren or to a friend who can't take the shot. Or to a friend who's so stubborn they won't take the shot. And I have friends like that, and I don't want to make them sick. I'm sorry. They may be stupid as far as I'm concerned. They may frustrate the heck out of me, but I don't want to have them be sick or die. I like them. They're my friends.
Will the vaccine it is likely that the vaccine hesitant will use the boosters as an indication that there's something wrong. Should we speak into that now as to what's happening with the vaccines, that they might need a booster?
I'm not sure what these people think that needing a booster means that the vaccines don't work, because every country that's successful, Iceland, for example, which has a 94% vaccination rate, has like no COVID. They haven't had a death in Iceland since May, okay? That doesn't suggest that the vaccines don't work to me. I don't know about you, okay? We're having 1,500 deaths a day in this country, and Iceland, which is a much smaller country, hasn't had it in months. It suggests that it works. Now, there's other ways to approach it. Like I said, Singapore has a lower vaccination rate, but they're much stricter about wearing masks and stuff. So there's different ways to approach it epidemiologically, but there's no evidence that vaccines don't work. In fact, even in this country, communities that have had vaccines, one of the things that made the news recently was the outbreak they had in Provincetown in Cape Cod. I don't know if you read about that. There's a big party there in September.
That's right.
But they had a very high vaccination rate, and there was an outbreak of COVID. People started testing positive.
Okay.
Do you know, did anybody go to the hospital or die? Nobody, because the vaccination rate was like 94 or 95% of that population. So again, they didn't test the vaccine to see whether you could get infected or test positive. They tested the vaccine to see whether you would die or go to the hospital, and it really seems to work extremely well. And needing a booster shot, like I said, to some degree, is really trying to flatten that curve more than it is trying to protect the individuals, because there's other means of immunity besides just antibodies. And so I still look at my booster shot. I don't want to make other people sick, but I'm not convinced that it's going to do me personally that much good, but I'll still get it. I think the risk is very low. I mean, literally hundreds of millions of people have gotten this vaccine, and I think you're more likely to die of a bee sting than you are to die of a COVID injection. And it's just being played all out of proportion. You know, people think that they're injecting tracers into you through microchips. I mean, why would they do that when you carry a cell phone? Really, they already have your number. So it's just I mean, these things are just patently nuts. I don't know what else to say about it. I shake my head when I have people say, you know, this is a conspiracy. Everybody's lying to you. All these people. I mean, the number of communists out there has grown exponentially. We haven't had this many. I mean, when they call Paul Ryan or Liz Cheney or a communist, you go, huh?
Should we be thinking of these COVID-19 boosters more like we're thinking about our flu vaccine, or we're all going back for annual vaccines?
Well,
we're in that season now. Is that just going to be part? Do you sense that's going to be part of the COVID array? Is we're just going to take an annual booster, and they'll probably put the two of them together, and away we go.
It's really hard to say. Flu is very different as a virus than coronavirus. Coronavirus is more like colds and stuff. And flu is influenza, which actually usually is much more virulent than a cold. I mean, you know. So it's hard to say. One thing that's interesting is Moderna is developing a combination vaccine where you can get your coronavirus vaccine and your flu vaccine and another vaccine, respiratory syncytial virus, which is another virus out there that causes like a pneumonia, usually in kids, but you get it all as one shot. So you may just get. Unfortunately, it's not going to be available this year. I get my flu shot too, And even though flu is only like a fourth or a fifth as virulent as COVID, sometimes it's worse. The flu varies a lot, and it's a big discussion about why flu is so different. But it is, and I don't. And you may need to get the booster shot. You may not. We don't know yet. It's only been around for a year and a half. Really.
Let's close with our emphasis, and that's on the vaccine hesitant.
Mm-hmm.
I think the ones in my orbit that I've heard the most is they're just not confident that it's been around long enough. And so possibly starting with that one, but then what are these reasonable reasons that are left? I think we've sort of explored some of the challenges that we've heard around our community, but what are those reasonable reasons that we can close with this evening?
Well, there aren't any. There really aren't. I mean, I think people feel that they are in on special information. You know, it's like you're part of the club. You know, wink, wink, nudge, nudge, and you don't believe in masks. You don't believe in the vaccination. My United Airlines pilot friend never gets sick. Doesn't need it. You know, and I wrote a letter to the editor. I don't know if you saw that about parachutes.
Why don't you tell that story again?
Okay, well, I wrote it as a pilot, not as a doctor, so I didn't sign MD after my name. But I said that, you know, there are at least 5 documented cases of people who have jumped out of airplanes without parachutes and lived. And there was one famous case of a guy who jumped out from 22,000 feet from a B-17 over France. He died in 2004 at the age of 83, okay? And he lived, okay? There are documented cases of people being killed or harmed by their parachute. And I said in my letter, I actually had a friend in the Air Force who was on the jump team. And he didn't put his harness on as tight as he should have. And when it deployed, it went, you know, right up there. And he almost ended up singing in a higher key. It was really likely they were able to save it. And he went on to a good life and had a family and so on. So it was a good ending to that. But you know, it just makes you cringe as a guy. We don't understand this. And what I said is that even in World War I, when parachutes were first introduced, people didn't want to wear them. Pilots in World War I did not use parachutes. They felt they were too dangerous. And they weren't sporting. They didn't have that bravado you needed to be a World War I pilot, where 1 out of 8 of them died, okay? And so I said, the virus is like the Red Baron, okay? You might never come in contact with the Red Baron. You might come in contact with them. You might shoot at your airplane, and you might still be able to land the airplane safely. But wouldn't you want a parachute just in case? And also, when I said in the final line of my letter, I said, how many people would have to have jumped from an airplane without a parachute and lived? And how many people would have to have been killed or harmed seriously by the parachute before you would be comfortable with your decision as you free fall from altitude, with your decision not to pull the ripcord? And that's what we're doing when we don't take a vaccine. We have the chute on. The chute's there, okay? Mm-hmm. We can pull that ripcord or not pull the ripcord. But personally, having done parachuting, I'm much more comfortable pulling the ripcord than not. And I would encourage people, if you're hesitant, think it over, look at where you're getting information from. Make sure you get it from reliable sources, not from a retweet from your cousin from Peoria about something they got from TikTok from an influencer. You know, go to cdc.gov, look at what they say, follow the recommendations. We have an excellent state epidemiologist, Christine Hahn. Do what she says, do what our governor says. People are trying to help you, to protect you and your community, and you should, even if you don't personally need it, maybe you don't ever get sick, you should do your part to help defeat this invading virus.
Wonderful. Dr. Weiss, thank you.
You're welcome.
I appreciate that. Before we close, is there anything you'd like to rephrase or restate? Are you okay with what we've accomplished tonight?
I have no idea. I'm sure I will have ideas later today, but I hope I have communicated that this is serious. We have the tools to fight this. We should come together as a community, as a country, and do our part, really.
Wonderful and well stated. Thank you. I really appreciate your investment of time, and we'll do our best to get these out to the people of our community. Thank you, Dr.
Sure.
Weiss. Well, thank you. That concludes our vaccine hesitancy series, and Dr. Weiss has served as our key collaborator in trying to understand this disease, what its treatments are, what its prevention is, and what we need to be doing for our part in our communities. And so thank you, Dr. Weiss, for doing that. We'll be moving on now, and our community conversation series will continue. And we're moving into the area of politics. And we'll be offering community conversations on our local candidates for local offices in our region. And so there's a variety of candidates that are available. And our politicians, as we learned from Commissioner Alt in an earlier conversation, are very involved in the vaccine conversation. So our politicians have something to say that's important into this topic, and we need to understand their positions. And so our community conversations will bring each of our candidates in that allows us to film them in this media, and we'll have a conversation with them on what their ideas are as we approach the elections in November. So I look forward to, on many of our Thursday nights in September and October, to have a conversation with our local candidates for leadership positions. And so I hope you'll join us in that endeavor to understand the political candidates for office. And so those will be on Thursday nights at 7 p.m. And so thank you for joining us. We appreciate your involvement, and we hope that you'll share this series with others that might benefit from the conversations that we've offered. And so take them to www.youtube.com/McCall College, all one word. And there you'll find the videos that will hopefully help them with information to come to a decision on vaccines. Thank you again for joining us. Join us on another Thursday night. We'd love to see you then. Thank you.